Hi, everybody. This feels like the Ellen Show. I thought I should have danced on my way out. I want to, first of all, thank everybody for being here today. This is no secret. I've been doing this work for 25 years. And I think you know both the rewards and challenges that this field has to offer. But one of the best things I always thought about this field are the people who do this work on a day in and day out basis. And I want to thank you very much for the work that you do. I also want to thank Linda Rosenberg and the National Council for inviting me here and for her leadership on these tremendously important issues. So I was looking at my notes that someone else wrote, and they were thanking the conference for having it in a warm place in Las Vegas. But I have to say it's warmer in Washington today than it is in Las Vegas. So just want to thank everybody for being here. But on a serious note, I cannot think of a better time to be having this conference and this conversation when there's such a national spotlight on issues around mental health and substance use issues. And I think you know the tremendous magnitude of the public health epidemic that we are facing now from overdoses, both from prescription drugs and heroin use. I think you all know this, but in 2014, more than 47,000 people, and I have a hard time saying these numbers, 47,000 people in the United States died from a drug overdose, with opioids involved in more than 28,000 of those deaths. More deaths since 2009 than have died in motor vehicle fatalities. But here is where you come in. The aims of this conference and the work that you do are really important to the basic principles of what I want to talk about learning new things and applying those lessons in the people that you see every day. And I firmly believe that with everybody working together, we can get through this crisis. So how are we going to end it? One, by evaluating where we are and dealing openly and honestly about where we are, about taking the lessons that we've learned and to adapt our approach along the way. And lastly, by building a movement to raise the profile of substance use disorders as a vital sign. So, I've been involved in developing and implementing strategies to deal with this issue with the opioid epidemic for well over a decade and with substance use for over 25 years at both the state and the national level. I've traveled the country listening to countless state, county, and local leaders, parents, people in recovery, medical and substance use providers, researchers, judges, police officers, and others to find out what's working and what further actions are needed to make headway against one of the most pressing public health issues of our time. Many of the talks that I've given over the past 2 years have focused on specific strategies that we are implementing at the federal level to address drug use issues broadly and the opioid epidemic specifically. And while our strategies are critically important in this crisis, I wanted to use this time to take a little bit of a step back and to look at what are the lessons that we are learning from this epidemic, and how do these lessons chart our road ahead. Excuse me. From my perspective, and this is certainly not exhaustive, here are some of the more critical ingredients that we have and will continue to make a difference. First and foremost, leadership matters. The only way we're going to get through this is if leaders at every level are engaged in this issue. I think most of us in this room have spent the better part of our lives convincing people that substance use needs to be a priority in our work. President Obama, presidential candidates, Congress, governors, local legislators are all focusing on this issue, and their continued engagement is a key component of the work that we do. Our office has been involved in the opioid epidemic since our inaugural strategy in 2010. And reducing drug misuse was also an important part of this initial plan. And we went further in 2011 with the administration's prescription drug abuse prevention plan, which focused on a number of main activities, including prescriber education, expanding prescription drug monitoring programs, proper medication storage and disposal, and our partnership with law enforcement in a broad effort to reduce the consequences of opioid use. But despite all of these efforts, we knew that we needed to do more. The first time that I met with the president, he asked me what he could do about this epidemic. And without hesitation, the first thing I asked him was to talk about this issue. Last October, I had the privilege to travel with President Obama to West Virginia for a community meeting about what we need to do to end this opioid crisis. While we were there, he announced a new presidential initiative requiring training of federal prescribers in safer opioid prescribing and to address barriers to access treatment for individuals who have opioid use disorders, and particularly focusing on medication-assisted treatment. I think you all probably saw that in the first few minutes of his final State of the Union address, the president urged Congress to take more action on the prescription drug and heroin issue. And just last month, President Obama released his fiscal year 2017 budget request. On top of increases of over $200 million over the past 2 years, he proposed the largest single investment in treatment and recovery support services of over $1.1 billion to close the treatment gap. So here's one thing that you can do. Some of us who are political appointees are not going to be here. So we're going to need all of you to advocate for additional dollars. But while the president's voice and action on this issue is important, if we're going to continue to make progress, we also need Congress, governors, mayors, local leaders, county, state, tribal, and the medical community to be involved and active in addressing this crisis. And here's something else that we've learned. We need a comprehensive and coordinated response to end this crisis. I think we all know that there's no silver bullet to ending substance use disorders. We need a multifaceted approach. And partnerships between public health and public safety are essential. You know, many of us who are doing public health work for a long time didn't necessarily like to let law enforcement know what we were doing. That has substantially changed. And we now have local law enforcement who want to be part of the solution and not part of the problem. It also means that states play a key role. They can take steps such as establishing effective prescription drug monitoring programs, passing Good Samaritan laws which encourage people to call 911 or otherwise seek medical attention during an overdose without the fear of arrest, expanding access to the life-saving opioid overdose reversal drug naloxone, which is saving lives all across this country. We need every first responder equipped to deliver naloxone when it's needed, and to make sure that friends and family of people at risk of an overdose have access to it. Our states can also expand Medicaid coverage and benefits so more people access substance use disorder treatment. Some have already taken a few of these steps, but there is still much room for improvement. Well, what else have we learned about this epidemic? First of all, it shed a light on some long-standing issues surrounding substance use, and if we are to continue to make progress, we have to squarely deal with them, and we are. I think you all know that as a society and for a very long time, we have largely relied on punitive approaches to people with substance use disorders. We thought we could incarcerate addiction out of people. And let's deal openly and honestly that this approach has had the most disproportionate impact on communities of color across this nation. In 1962, then Attorney General Robert Kennedy, in one of the first meetings at the White House on drug issues, said that our response to addiction has focused mainly on law enforcement, and we need a more robust health response to addiction. Drug reform policy is criminal justice reform. It is truly gratifying to hear law enforcement say that we can arrest our way out of this problem. At a recent town hall forum in Ohio, I asked the sheriff of Toledo what one thing he would like to see from the federal government. He didn't ask for more officers. His response was that we need more treatment services. I know. For too long, substance use has gone largely ignored by the rest of the healthcare system. Lack of medical education, separate care and delivery systems, misaligned financial incentives. It is still astounding to me that only 20% of people who need treatment actually get it. Compare that to diabetes, where almost 85% of people get treatment. And of those who get it, most are either referred by the criminal justice system or self-referred. Only 8% of our treatment admissions come from the general healthcare system. We have come to expect that people's motivation to change can only come when they have hit bottom or when the specter of the criminal justice system hangs over their head. We do not do this with any other health condition. We need to increase medical education on substance use and prescribing behavior, routinely screen, diagnose, and refer people to treatment, continue our efforts to integrate into primary care settings, and like we do with every other chronic condition, continue to motivate people to change at the earliest possible moment. We also have recognized that there are historic inequities for funding, insurance coverage, and parity for substance use disorder treatment. We stand to correct that through the Affordable Care Act, parity legislation, regulations, and enforcement, and increasing funding for treatment and recovery support services. We have also learned that despite the dramatic increases in knowledge about proven strategies for prevention, medication-assisted treatment, syringe access programs, they have not been widely implemented. Well, why is that? A while back, a former federal official, and no, David Mineta, it's not you, taught me a very valuable lesson. Science and data alone are insufficient to drive public policy. People drive public policy. Just as important to our scientific advancement is our political advancement. Many of you in this room have had a long history in dealing with the AIDS epidemic. Not that long ago, politicians wouldn't utter the word when obituaries didn't mention it or use code words or conditions. People with AIDS were marginalized and stigmatized. There was a lack of research, treatments, and funding. But out of the grief of those deaths was born a social and political movement, so much so that the end of the scourge of AIDS is within our sight. So too has this epidemic spurred one of the most important lessons. Advocacy is perhaps our most important tool. Presidential candidates are talking about this issue because parents with great courage have gone to town hall meetings and raised their hands and pressed for a response. Because people in recovery are unafraid to become visible and vocal. Where there is a movement to rid the shame and stigma that prevent people from seeking care. Out of this tragedy, we have been given a moment in time to address these issues once and for all. This is our time. I firmly believe that we can and we will turn the corner not only on this epidemic, but on these long-standing issues. As President Obama said in West Virginia, when it comes to treatment and recovery, those things are possible if we work together. Thank you very much. Any questions? Great. So I think we have some time for questions. If people want to ask questions, please.
I live in Alaska, and I run, among a bunch of programs, at Therapeutic Community. It was founded 41 years ago to serve opiate users. So what I have seen is, yes, there's an increase in opiate use, but nobody noticed it till it hit the middle class. And even then, my legislators, and we're in the midst of a legislative session, I had the head of Health and Social Services Funding Committee say to me, we're hurting for money. I don't have time to worry about somebody who won't give up the bottle, sticks needles in his arms, and expects me to care about him. That tends to be, at least in our state's legislature, the operant belief system. How do we work on that?
Sure. So the question, if you didn't see it, she's from Alaska, has worked in therapeutic communities for, I won't say how many years. I did hear how many years. A long time. And said, you know, we've had opiate addiction before, right? But because now it's become kind of a nice, white, middle-class issue, it's gotten a lot of attention. But she still hears from her legislature that, and I'm paraphrasing, that people did this to themselves, right? So why should we care as a state in terms of what people to do? Well, you know, so a couple things that I want to address. That one is, you know, we've had issues of addiction, and particularly opiate addiction, in many of our communities for a very, very long time. And again, I think a lot of our response to this had racial overtones to it. And we thought that, you know, with the crack epidemic, if we just arrested and incarcerated everybody. And I like to say that we've learned a few things in terms of what we know to be effective. But I also think that a couple things. We need to use this as an opportunity to make sure that we're implementing those solutions and making sure that those solutions work for everybody. And the second thing, how do we change people's perception around this? And this is, I go back to my point, science and data don't drive public policy. People drive public policy. So all of you have been watching the presidential debates, you know, where now it's almost become, I don't want to say fashionable, that's probably not the right word, it's become open for people to talk about how addiction has focused their own lives. And I think we have to continue to promote that this is not a disease of other, that this is a disease that impacts every family, and that we need to promote, that we need to highlight that. But I also think that we need to continue to work with the recovery community and really highlight the fact that people can and do get better. Because I often think that there is this overriding influence that treatment doesn't work and people continually relapse. And we know that's not the case. When people get good care and treatment, people do get better. So that's why, you know, advocacy and openness become tremendously important in the work that we're doing. So, you know, keep up the efforts. Good. I think we have some microphones here if people want to go to the microphones.
Hi, Michael.
Great.
Richard Nance from
Hi,
Utah.
Richard.
I bring you greetings from the Utah State Legislature.
Thank you.
I had a copy of Senate Concurrent Resolution 11 to ask for marijuana to be moved from Schedule 1 to Schedule 2 so we could do some research on it, but I left it in my other briefcase. I'll just mail it to you. So that's the question. What will we be able to do at the federal level to have a more robust research agenda on medical marijuana, because there's a lot of chaos and misinformation.
Yep. You know, I agree, Richard. Thank you for that question. So I think there's a lot of things that we can do short of rescheduling marijuana to Schedule 2. And we at the federal level have been working on a lot of those initiatives. So let me tell you a couple things that we've done. One is NIDA, through their grant, has actually tripled the amount of marijuana that they grow for research. And we clearly have signaled a desire to do more legitimate research on the components of medical marijuana. I think we would all agree that smoking a medicine is probably not the most efficient delivery device. So NIDA has really amped up its research on that. We worked with HHS to actually, one of the things that we had what many people considered a redundant approval process in HHS that required a review of medical marijuana research. So the Secretary actually just announced a number of months ago that we were doing away with that redundant process. So, you know, I do think that in some respects it's a fair criticism that the federal government didn't do enough to do some legitimate research. I will say, however, that I'm really concerned about some state laws as they pertain to the kinds of conditions that they prescribe medical marijuana to, and I think we need to rely on a scientific process to determine what's appropriate use of the components of marijuana.
I wanted to give you one other little piece of news. Thanks for coming 2 years ago and talking about naloxone. We have a needle exchange bill that's this close to passing the legislature.
So, so a couple things, which is great. You know, one of the things that we've seen with this epidemic is not just around overdoses, but dramatic increases in viral hepatitis associated with injection drug use. I'm sure you all saw what happened in Scott County, Indiana this past summer. So if you didn't, Scott County was a very small county of 9,000 people in rural Indiana, had about 5 new cases of HIV. Well, as a result of sharing needles because of with prescription pain medication, they had over 180 new cases. So, you know, this was a county that had very little treatment resources. They had little aid services. And so let me tell you, I think one of the things that happened at the federal level, which is really important, after decades with the FY16 budget, Congress repealed the federal ban on syringe access services funding. And the other piece, so we've been working with governors' offices around this. You know, we have many, so this has been a pretty bipartisan effort, you know, to repeal the ban. And we also have many governors who are moving forward with states that don't have syringe access legislation to be able to do it. So again, I think it's, you know, it's part of our comprehensive response that we have to really take a serious look at. Thank you.
Hi, I'm Carol Homrig, and I am with Prevention First. We are a substance abuse prevention training and resource center in Illinois. So I just heard you reference, yes, thank you. You work with governors. Is there any way you could possibly come to Illinois, maybe just a little technical assistance there would be greatly appreciated, as they provided zero funding for substance abuse prevention for the past 2 years.
I know.
So I would appreciate your guidance too on substance abuse prevention. Doesn't seem to be a really big part of the dialogue, and yet we, you know, philosophically and intuitively know that prevention is cost effective, much more cost effective than incarceration and, you know, emergency room expenses, etc. So what are we in the world of substance abuse prevention perhaps doing wrong, or what do we need to do differently so that I think I saw the drug-free community support funding as being chopped or being proposed to be reduced. So what are we doing what do we need to be doing differently to change that up?
So a couple things. And one, I would agree that I don't think, particularly as we've talked about the prescription drug and opioid epidemic, that we talk enough about particularly primary prevention and its role to do that. So, you know, we need to continue to work both with SAMHSA and other folks to continue to access prevention. As part of the CARA bill that's being debated right now, there's actually language that would support additional primary prevention goals, because I think that's really important. I think we all know that while we talk about prescription drugs and opiate epidemic, and there are some people that do develop addiction solely on the fact that they're being prescribed, but we also know that the vast majority of people start from a very young age, often with alcohol, tobacco, and marijuana. So the other piece I would just say, and again, this is why I think advocacy becomes important, because I think you need to work with your state, with your legislature, and with your governor's office to really make sure that you're advocating for this. Governors need to see it as a priority. We've been working very, very closely with the National Governors Association to, one, both hear their concerns about what they want, but also challenge them, I think, to do more work in these areas. So thank you very much.
Thank you.
Great.
So my name is Bill Denahan. I represent the Alcohol Drug Board in Cleveland, Ohio. And when you come there for the convention, I hope that you stop by and learn what we're doing. We have found that heroin mixed with fentanyl has an extraordinary death rate, going from around 200 a year, which was about 50 a year 4 years ago, to now exceeding 350 a year.
Great.
It has caught us in terms of our lack of capacity. It's a death sentence to tell somebody come back in 2 weeks when they're going in there for a test.
Yep. Good.
So when you speak of the additional treatment, more treatment for long-term beds. We thought we were doing the right thing by putting them in there for 30 days. Doesn't work.
Yep.
They need 6, 7 months, and the longer they're in there for treatment, the better they are, and the better success they are in the recovery. So I'd hope that you would visit us and learn what we're trying to do. This epidemic has caught us with a total lack of capacity to deal for those that want treatment and going into treatment.
Great.
So we'd hope
Good.
that when you're looking at the funding, that you consider one of the most expensive parts of funding is residential treatment.
Good. So thank you. I think the issue that you raised, we've seen in many states. So, you know, the dramatic increase in deaths in many, many states can be attributable to both heroin and fentanyl-laced heroin. I think it talks about how we need to work with our law enforcement folks to make sure that we're getting the supply of fentanyl out of your communities. I don't think you'll get a disagreement with anybody about, you know, the need for additional resources for long-term care. But I will say one of the issues that we've been focusing a lot of attention on is medication-assisted treatment. Right? And, you know, we've had lots and lots of conversations. Actually, the Washington Post yesterday just had one of their 5 myths about heroin. And basically, it said that medication-assisted treatment is widely underutilized in our primary healthcare system. It's widely underutilized in our treatment system and widely underutilized in our criminal justice system. And part of what SAMHSA has been focusing on and the president's new money are to train more prescribers to be able to administer buprenorphine. Secretary Burwell just put out $100 million this summer to increase the capacity of community health centers, because we know that community health centers are in parts of the country where we might not have treatment programs. There are multiple paths to treatment. We want to make sure people have access to the full continuum of care, but we also want to make sure that people have access to medication-assisted treatment.
Well, there's another part you can help. There's an IMD exclusion in which there's a limit of 16 days, or at least 16 beds in any system that has been put in there since 1963. Doesn't work for today.
Yep.
Removing that exclusion will open up hundreds and thousands of beds across this country that have the ability to put those extra beds out there.
Great.
And have that come through Medicaid.
So I've heard this a lot. So actually, the Center for Medicaid and Medicare Services just this summer put out a letter to every state Medicaid director. And part of what they're saying is that we are willing to work with states to look at how do we expand the continuum of care for people with substance use disorders, and a willingness to look at the IMD exclusion and to waive the IMD exclusion as long as states can demonstrate that they're having a full continuum of care. And that there are a number of states that are working with CMS now, and a number of states, I believe California and New York, that have already been able to work on that. So it's a pretty important point. We have a number of people, so I'm gonna go to the next person.
My name is Paige Prentice. I'm from Horizon Health Services in Buffalo, New York, and it's not exactly warmer in Buffalo today, but it's close. I do want to speak about the access.
Do you want to go back to Buffalo, or do you want to stay here?
Well, I don't know. I do want to speak about access to medication-assisted treatment. So in terms of strategies to immediately impact access to medication-assisted treatment, what are we doing to allow nurse practitioners and physician's assistants to be able to prescribe buprenorphine like they can any other Schedule III narcotic, at least in New York State,
Good.
Anyway?
So it's a really important issue. So first of all, that literally requires an act of Congress to change Data 2000 to be able to do that. Senator Markey and a number of other people have legislation right now. So, your advocacy with your congressional delegation to look at passing that become important. Part of what we looked at with both HHS and SAMHSA and part of the FY17 budget proposal was to at least allow for demonstration programs where we could do it to allow nurse practitioners and PAs in states where they already can prescribe to be able to do this, because we want to make sure that we continue to do it. I think it's a really important issue for us to do that. We're also working at getting an increase to the number of physicians who can do it and putting out resources for integration with primary care. We're also, and the Secretary announced this at the West Virginia visit with the President, we'll also be releasing very shortly proposed regulations to look at, in certain situations, to lift the cap that we have on the number of patients that we can prescribe. So we're really looking at a whole host of issues to be able to do that. So, great.
It's going to take a long time. Okay.
Dwight Holton from Lines for Life in Oregon.
Who?
Dwight Holton.
I'm only kidding. I'm only kidding.
So 2 questions. One, the nature of the prescription drug abuse crisis has brought healthcare systems to the table on addiction treatment like never before and addiction prevention like never before. We're getting a handle on the prescription part of this challenge. We're going to turn a corner. How do we keep them at the table when we still have the resident heroin problem? Because that's a healthcare system problem too.
Yep.
That's question 1. Question 2, when will the CDC finalize their very progressive and thoughtful guidelines?
So I'll start with the second part of your question, soon. No, and I will say that there was some extraordinary number of comments. I think it was over 4,000 comments that they received on these. So, and they have to go through a process where they review the comments, they look at how they're going to do it. But, but we know, the Secretary knows, that this is an important priority.
Well, and I ask so you can go back and say, oh my God, they're getting this wrong.
No, we know. Believe me, I think this is important. But here's the other piece too, and again, I think we need to capitalize on the momentum that we've generated. And again, you know, I think it's important to remind people, you know, sometimes, you know, and we've thought about this when, you know, people hear heroin and they get all freaked out, right? But part of what we want to remind people is that 4 out of 5 newer users to heroin started by misusing prescription pain medication. So we've got to continually remind folks that if we want to really turn the tide on this, that, you know, that the prescription drug issue is part of the root of the problem here. And that's, I think, you know, how we have to continue to make sure that they're at the table. The other piece that I will say is, you know, this is where parity and parity enforcement becomes really important. That people need to work if they feel like there's parity violations as it relates to how insurance companies are dealing with this, whether it's heroin or prescription drugs, that they should take that up with their state insurance commissioners in terms of the work that they're doing.
It's just been great to have these people in the room because they can move boulders that were impossible to move when it was just heroin. And I want them there when it's heroin mainly.
No, but right, this is why I talk about, this is our opportunity, right?
Yeah.
These are long-standing issues that we've had in the field of addiction, right? And so part of it is I think we have to capitalize on this opportunity to deal with issues, not just as they relate to prescription drugs and heroin, how they relate to how we treat people with alcohol use disorders and with cocaine disorders. So we have to use this as an opportunity to really address some of those long-standing issues. Good to see you.
Hi, Michael. Ray Tomasi from Gosnell on Cape Cod.
Hi, Ray.
Nice to see you.
Nice to see you as well.
My question is about the workforce issue, and so I wondered if I could hear your thoughts about that issue. Number one, the current workforce that's trying to respond to the demand that we have because we face significant shortages, and then the workforce training opportunities as we begin to think about treating this in a much more chronic disease management way, so which means treating people in non-traditional settings like physicians' offices or integrated settings. And it seems that we're trying to move service capacity into new settings. I just don't know where the workforce is coming from and where the trained and competent workforce is coming from.
No, I think that's a valid issue. And as we were talking about this, I said to June Savilli, who runs our treatment bench, I'm going to get a question on workforce. And Tom Coder here is from SAMHSA that's been taking a lot of the leadership as it relates to workforce development. But you're right. I think that some of this really challenges us to think not only kind of do we have a prepared workforce, but do we have a workforce that's prepared and to work in settings where they're not historically been worked before. So, and there's, I think, a lot of innovation and work that's happening about using trained peers in emergency departments. How do we embed recovery coaches in primary care settings so they can be part of the team that's administering buprenorphine? You know, one of the things that I heard, there was a police chief in Dayton, Ohio, who implemented this program. It was called Conversations for Change. Right, and so they follow up with everyone who's gotten an overdose, and they have specialty trained peers in motivational interviewing, and they do follow-up. So, I think it's an issue that, but with not only the Affordable Care Act, but really challenges us to think about how do we have a workforce that's trained, and not just a physician workforce, right, but nurses, physician's assistants to be able to do that. And so I think we need to kind of continue our work really focusing on this workforce and not only looking at the traditional settings where they're working, but looking at some of the non-traditional settings where we want this field to go.
Thank you.
Thanks, Ray.
I'm Noelle Shank from Davis Behavioral Health in Utah. My question is about naloxone rescue kits. We're working really hard to try to prescribe it to everybody with an opioid use disorder diagnosis, as well as anybody who's on chronic pain management. The problem we're running into is insurance companies put up barriers. We have to do prior authorizations, sometimes taking as long as a month for them to be approved, whereas the same prescription for oxycodone or hydrocodone is immediately approved. What can be done to help remove these barriers? Because the longer duration from the time we write the script till it's approved, the less likely the family or the patients can actually pick the medicine up.
Mostly commercial insurance?
Yes.
I know. I figured that. So let me talk about what we're trying to do on the Medicaid side first. But so one of the things that we are working with state Medicaid directors is to do work around their formulary in a number of different areas. One, making sure that naloxone is on their formulary list so we can get Medicaid reimbursement to do it. The other piece that we want to focus on is their Medicaid formularies. There are some states that still have methadone for pain at the top of their Medicaid formulary, largely because it's cheap, even though overdoses associated with methadone for pain are high. I do think, and we've had this conversation with HHS about how we can engage commercial insurance plans in a whole host of activities, not only about naloxone and naloxone reimbursement, but things like formulary design and benefit design. So I think that there are opportunities ahead of us to work particularly with commercial insurance plans, and look at their formulary design to support not only naloxone on their formulary, but other things as well. So, the other thing that I'll say too is that we, despite all that, at the federal level, over the past few years, we've been trying to get additional money out to states and locals for naloxone and naloxone purchase. To be able to do that. So there are a number of grants that do that. SAMHSA actually, I think 2 years ago now, sent out a letter to state subsidies directors looking at the block grant for an allowable use of naloxone. So we are trying to put grant monies on the street to be able to do that.
Thank you.
Hi, Director Botticelli. My name is Dan Mistek. Good to see you again from Community-Oriented Correctional Health Services, or COACHES. And I just want to say thank you so much for all of the work that you've done at the federal level in order to make sure that we really are starting to look at the opioid epidemic from a population health approach. But I want to say that there's still a major blind spot in our population health approach to solving this crisis, and that's our county jails. What we've got going on right now is the IMD has really opened up this opportunity in order to make sure that folks who could use residential services are being able to receive them now at an IMD. But there's a separate track for folks who tend to be black or brown, tend to be poor, and that's our county jails. Yep. And often in those jails, there might be interventions that help, and then once those folks are back out in the community again, we have no idea what's going on. So I was just wondering what we could possibly do in order to do that, and if one of our advocacy issues at COACHES is to say, why not bring an 1115 in just the way that we've done it with the IMD? It's the exact same statutory bill that we're trying to work around. Why would something like that not work?
No, I think you're right. And I know it's been a challenge, and we've heard a lot of folks at the county and local level in terms of Medicaid not being able to reimburse for services behind the wall. And I think there's, that's been a lot of discussion. There's actually been some legislative action to allow for Medicaid expenditures for people who are behind the walls. One of the things that I think we have been trying to promote are a couple things. One is, how do we make sure that people who are in our county facilities are getting good care and treatment, and make sure that they're being able to do that through second chance grant funding, look at the federal grants to do that, as well as how do we think about suspending Medicaid benefits instead of terminating Medicaid benefits for people who are incarcerated, so that you can turn them on as soon as people come out, and how we think of transitioning people. I know the White House Reentry Council actually put a myth buster out, because I think there is this myth that you have to terminate Medicaid benefits for people who are incarcerated, and we know that's not true. I was just with June at Middlesex County Sheriff Office, who's doing a lot of work behind the walls. Ray Tomasi is also working with Barnstable County Sheriff's Office to look at how do we transition people, particularly using medications, as they're coming out of facilities and hooking them up with community providers. So I think we're seeing a tremendous amount of innovation from our county folks about understanding that we need to give good people treatment behind the walls, and look at how we transition people back to the community. Thank you.
Hi, my name's Debbie Davis. I'm a nurse practitioner at the Spokane Regional Health District Opiate Treatment Clinic.
It's worse than my title.
Huh?
It's worse than my title.
You should see it on my business card. Couple of things. One, nurse practitioners, physician's assistants, mid-levels can just really be of major help in filling in a hole in providing care, acute care, and sustaining care to these clients. in family practice as well as in an opiate treatment clinic, especially if you can get the wraparound care of mental health, physical health, and the addiction treatment. It would be really nice if we could get some consistency nationwide as to what nurse practitioners can do rather than just the state here can do this, the state here can do this. I'm running into being restricted in signing for methadone even though I have prescriptive authority for Schedule 2 to 5 because of federal laws. I have to wait for my physician who comes in twice a week to sign my orders. And it just makes no sense for that lack of consistency and that lack of ability. Ego. I know what it is.
I know.
The other piece, two other things, and I'll get out of your hair.
No.
One concern I have for these clients, and I just really like that this conference is addressing this, is the care when clients leave treatment, when they start running into situations that trigger their relapse signals, and trying to intervene there rather than getting them back into the clinic again to restart the process, which is very boring to them. The third piece is I really like how medical schools are starting to really teach addiction, pain management. And nursing schools, there's not enough information getting to the providers in these specialties, and it's a huge issue in primary care, family practice.
Yeah, no, I would agree, and I think part of what we're trying to do at the federal level is look at how do we integrate addiction treatment as part of ongoing medical education, and not just for physicians, for a wide variety of folks. You know, this is why we've also continued to pursue mandatory prescriber education for every prescriber in the United States. So here's a fun, not so fun fact, I guess. We comprise only 5% of the world's population, yet we consume 85% of the prescription pain medication in the United States. And this is from very well-intended, often well-intended prescribers who think they're doing the right thing, and we just need to make sure that they get education to do that. Again, you know, most of the time that I wish we could do more at the federal level in terms of the practice of medicine, that's usually a state-level decision. But again, you know, we particularly looked at around buprenorphine prescribing, and there was nothing that we could do at the federal level short of changing the Data 2000 legislation. So your advocacy at the federal level to modify Data 2000 to let people do that becomes important. You know, one of the other pieces that you mentioned in terms of you know, people leaving care and transitions. Let me put out a couple things. I know many providers here have been working with the Network for the Improvement of Addiction Treatment, right, NIATEX, and I think you saw this. So one is you as providers can do a lot of things to minimize the wait time that people have to come in, and many providers have been working on this for a long time. The other thing that I'll say is I also think it's an opportunity to review your administrative discharge policies. I can tell you that my experience in Massachusetts was that providers, very well-meaning, in essence, were kicking people out for exhibiting the symptoms of the disease that they had, right? So yes, we need rules. Our programs need rules and guidance. A lot of our people, I can say this as a person in recovery, need structure and guidance. But we also have to make sure that they are not so overly punitive that the few people who get into treatment are getting kicked out for things that probably don't make sense to do that. So I think you have an opportunity to do that.
Things that, do we really have control over it anyway?
I know.
How can we enlarge protection or treatment?
Yeah, good. Thank you very much. Hi, Kathy.
Hi, Michael. Kathy Wilson from Springfield, Massachusetts. I'm really struck in these campaigns with the number of youth that are coming out to really get engaged in politics. And I'm very worried about the youth that need preventative training and intervention and education about the addictions that we're seeing. In my area, those that have recently died have been in the ages of 14 to 25. And I'm really worried that we're not seeing enough resources for prevention, for particularly the youth population. And if we could capture some of the enthusiasm that we're seeing that's unfolding in the young population to engage other youth and do a better job, I'm wondering if you had some thoughts about that.
I would have a tendency to agree with you, Kathy, that I think that we need to continue to look at ways that we expand prevention services, particularly at the community basis, because you're right. We're charting a course that I think is really destructive for a lot of youth. And I will say, we have been very vocal about not being in favor of legalized marijuana. And so we, and particularly folks in the prevention world, have had some great successes. So we see dramatic declines in alcohol use, dramatic declines in tobacco use, dramatic declines in virtually every other substance except marijuana. And if any of you looked at the data, the perception of risk of marijuana use among youth in our country is at its all-time lowest levels. And for those of us who worked in the public health field for a long time and had to sue the tobacco industry for things like cartoon characters and flavored cigarettes, and we're seeing a $1 billion marijuana industry that are using the same tactics to go after not only our youth, but so there was a study that came out of Colorado that showed the vast majority of stores in Colorado are, guess where? In poorer communities and communities of color. And we see that with the alcohol industry, and we saw it with the tobacco industry. So yes, I get the social justice or the criminal justice component, that we shouldn't be having people arrested and incarcerated for marijuana, simple marijuana possession, but I don't think legalization is the way to go. But I do think, Kathy, the road ahead, we really have to look at amping up our prevention efforts.
Yeah, I'd love to see some money. I mean, I think it's coming for prevention, well needed, and certainly in Massachusetts, we're seeing our present governor making better investment, but I'd love to see some prevention money too.
But we did get additional resources in the FY16 budget for both the SAMHSA block grant and the SPIFSIG funding for enhanced prevention services. So there was some additional resources around prevention-related services. Thanks, Kathy.
Good afternoon, Mike. I'm Bob Brown from Arlington, Texas. I saw a TV segment the other day about the LEAD program, Law Enforcement Assisted Diversion. I assume you're familiar with it?
Yes, I am.
Is there any studies being done, or are there any studies being done at the federal level that you're aware of about that kind of a diversion program?
Yeah. So if you haven't seen it, there was actually a Frontline special a couple of weeks ago on the heroin epidemic. And the good news is that, it basically showed that even within the law enforcement community, there's an appetite to divert people away from our criminal justice system. So the LEAD program, Law Enforcement Assisted Diversion, has been going on, I think, for a number of years, started in Seattle, which is where the program is. And I actually just met with the program leadership the other day. And what they want to study, one of the questions that I asked them is, it appears to be effective in reducing recidivism and reducing arrest. What they're continually studying is, does it also reduce drug use? And does it provide an accelerant for people to get into treatment? And that's some of the evaluation that they're doing now. One of the things that I don't think we have a lot of research on and evaluated programs, I hear this from law enforcement all the time. They say to us, what are those programs, what are those evidence-based programs that can move people away from the criminal justice system and into treatment? And we just don't have a huge research base on those programs. I think many of you saw there was a police chief in Gloucester, Massachusetts, that's now being replicated all across the country, where he's basically said, come into my police station, regardless of your criminal charges. I will get you into treatment. I'll provide case management services to get you there. So I think there's a huge appetite among law enforcement officers to look at what are those programs that reduce recidivism, reduce crime, but also provide an opportunity to get people into care and treatment. So we're going to be very interested in their subsequent evaluations to see how that comes out. Thank you.
My name is Darlene Webb from North Carolina. My question is, what is your take on 42 CFR Part 2 and the barriers it's causing with integrated care, particularly...
Are we out of time?
Particularly, we are struggling with the pregnant opiate population. We have natal abstinence units that are high rates at our hospitals, and it's virtually impossible to coordinate care quickly because you can't deem a danger to self or others right at that moment.
Yep. So first of all, you know, one of the things that has been disturbing to me is that while we've gotten a tremendous response from law enforcement and legislators about criminal justice reform, I'm afraid that many states are going backwards as it relates to pregnant women with opiate addiction. We've seen several states pass legislation that have put enhanced criminal penalties on pregnant women. And we've seen this time and time again, where they think that if we basically give them enhanced criminal penalties, that's somehow going to encourage more pregnant women to come into care. And we know that's not the truth. So, and I think you can play a great role to make sure that we're not backsliding as it relates to how we're dealing with pregnant women on this. You know, as it relates to 42 CFR, and Tom Coderre is here from SAMHSA, I'm not going to ask him to speak, but, you know, SAMHSA has been engaged in this process to look at how can we modify 42 CFR to really focus on promoting those things that we want to be able to do in terms of mainstreaming addiction as part of our general health care condition, and look at making sure we're having appropriate sharing of information without kind of re-stigmatizing people in terms of the reaction of their medical provider to do it. So I think that we and SAMHSA are trying to strike this balance and look at what are the opportunities to modify 42 CFR to provide for that enhanced information sharing but also acknowledging that sometimes disclosure of that information, even to a medical provider, can result in a tremendous amount of stigma. So, you know, I think we need to continue to look at our confidentiality laws as we go forward here, in terms of, you know, how do we continue to make modifications to them, or at some point, you know, is 42 CFR no longer necessary because we're seeing this as part of general health care. So, and I think we have a ways to go. So, but, you know, if you want, SAMHSA can give you more information. I think that they're out for comment. So if you haven't seen them, the proposed modifications are out for comment now. Great, good. Well, there's no more questions. I just want to thank everybody for the great work that you're doing. Again, I think that this is a tremendous opportunity for us to really make some changes in some longstanding issues. I want to thank you for all the work that you do on a daily basis. Thanks, everybody.